Welcome to Chapter 17, Nursing Management, Patients with Arrhythmias and Conduction Problems of the Heart. Arrhythmias, often known as dysrhythmias, are disorders of the electrical impulses within the heart that can cause disturbances of heart rate, heart rhythm, or both. Arrhythmias may initially produce symptoms related to the hemodynamic effect they cause, such as a decrease in blood pressure or cardiac output. Some arrhythmias increase the risk of clot formation within chambers of the heart, and these will be discussed in later slides. The following slide shows the SA node, AV node, the bundle of His and the Purkinje fibers in relationship to the EKG complex that you see on the paper or the monitor waveform. If you note, conduction through the SA to the AV node signifies the P wave, and most particularly for our measurement purposes, the PR interval. The QRS shows conduction through the AV node and down into the bundle of His, and that is signified by the QRS complex, the QT interval. The conduction from the bundle of His through the Purkinje fibers is the QRS complex, and that is the other major measurement that is done in EKG interpretation. So to sum up this slide, the most important things that you'll look at on this paper are the P wave, the PR interval, the QRS complex, and its measurements. Each phase of the cardiac cycle is reflected by specific waveforms. Electrodes on your patient record waveforms that appear on the paper or monitor and represent electrical current. The use of 10 electrodes, which result in a 12-lead EKG, provide detailed diagnostic information on our patient. A couple of things to remember about this: accurate placement of the leads is crucial, and various forms of continuous EKG monitoring are available. This slide here shows two EKG complexes and how they are measured. So if you look at this slide, you'll notice that atrial depolarization will cause a deflection known as the P wave. The PR interval is used in rhythm interpretation. Measurement of the PR interval is what we look at when we interpret EKG rhythms. The normal duration of the PR interval is 0.12 to 0.20 seconds. And if the impulse originates in the sinus node, the P wave will be upright, and it's measured from the first upright elevation of the P wave to the beginning of the QRS complex. For brevity's sake in these slides, the questions will be covered in class. This slide here shows EKG measurement. EKG measurement is done in a horizontal plane across the paper, and it's done in duration of time. And if you notice in this slide, it's one of the larger, heavier bolded boxes is pulled out of the slide to show that when you have just one of these boxes in measurement, that it's 0.20 seconds of time in measurement. If you pull a smaller box out of those boxes, you'll get 0.04 seconds in time. And this is how EKGs are measured. This slide here shows relationships to the cardiac conduction of the electrical impulse that goes across on the monitor. If you'll note in this slide, the P wave is significant with atrial activation. The QRS complex is significant with ventricular activation. And the recovery wave, or the recovery phase of the cardiac conduction cycle, happens during the T wave. In this slide, it shows a normal sinus rhythm. The characteristics of normal sinus rhythm are that the heart rate is 60 to 100 beats per minute. The rhythm is regular. The P wave is noted before each QRS, and each P wave is identical in shape. The PR interval is 0.12 to 0.20 seconds, and the QRS complex is less than 0.12 seconds. The next slide shows a sinus bradycardia. The only difference between sinus rhythm and sinus bradycardia is the rate. The heart rate in sinus bradycardia is less than 60 beats a minute. The rhythm is regular. There's a P wave before each QRS. It's identical. The PR interval is consistent at 0.12 to 0.20, and the QRS duration is less than 0.12. If sinus bradycardia develops a rate that is too low for the patient to be comfortable, you may see signs and symptoms of poor perfusion. This is due to the low ventricular rate. Oftentimes in your patients, you'll see low blood pressure, nausea, vomiting, and other types of symptoms that go along with poor perfusion. Treatment for sinus bradycardia consists of atropine. Atropine increases the heart rate. Another treatment to treat the low blood pressure, if it continues to be a problem, is a vasopressor called dopamine. Dopamine in and of itself does not increase heart rate, but it does support the blood pressure. However, most textbooks, you'll note, if dopamine is given at the standard maximum dose, you will see an increase in heart rate. If atropine and dopamine are unsuccessful in helping your patient recover, then either temporary or permanent invasive pacemaking is indicated in these patients. Sinus tachycardia is the slide you're showing now. A sinus tachycardia is actually a sinus rhythm with a heart rate that's greater than 100. The rhythm is regular. There's a P wave before each QRS, and it's identical. The PR interval is 0.12 to 0.20, and the QRS duration is less than 0.12. One of the things to note in rhythm interpretation is that it's crucial that you identify the underlying cause of the dysrhythmia rather than just treating the symptoms. Treating the symptoms is important, but if you don't identify the underlying cause, you're not going to get the rhythm to change. Treatment in this case, ID the cause. A couple of common causes of patients with sinus tachycardia are fever, low blood pressure, low blood volume, or anxiety. Most sinus tachycardias are not treated with any types of cardiac medications because most of them, if you identify the underlying cause, you'll be able to treat the rhythm. Is the following statement true or false? Sinus tachycardia is characterized by a normal PR interval, but an irregular rhythm. This answer is false, and the answer below shows the characteristics of sinus tachycardia. Atrial fibrillation. One of the things to remember in atrial fibrillation is that there is no visible uniform P waves, and it's irregular, irregular, irregular. Atrial fibrillation is just as it is described. The atria themselves are fibrillating rather than producing a conducive conduction beat that is synchronized. Therefore, rather than producing an effective cardiac output, the fibrillation of the atria causes blood to pool in the atrium. In this type of a patient, it's absolutely crucial that if a patient is going to remain in atrial fib, that they're anticoagulated. And often in the emergency department, these patients are anticoagulated until we can identify the cause of the atrial fibrillation and treat the problem. The heart rate in atrial fibrillation, oftentimes the atrial rate is 350 beats a minute or more. The ventricular rate can be slow or it can be rapid. And most of your problems with your patient stem from whether or not the ventricular rate is rapid or is too low to sustain an effective cardiac output. The rhythm in atrial fib is irregular. The P waves are absent because they're fibrillating, not creating an effective P wave. There is no PR interval. Most of the time, the QRS complex is less than 0.12. Treatment for hemodynamically unstable atrial fibrillation is cardioversion. And cardioversion is done with a cardiac monitor in the synchronized version. Other treatment for atrial fibrillation is anticoagulants such as heparin or Coumadin. Heparin is done in the initial new onset of atrial fibrillation because of its ability to take effect in the system quickly. Coumadin often takes 3 days at least to become therapeutic within the system, and so if somebody presents to the emergency department in a new atrial fibrillation, they are immediately started on a heparin drip, and they may be started on the Coumadin at the same time to avoid the patient throwing any clots into the brain. Other treatment for atrial fibrillation is ablation, where the patient is sent to the electrophysiology lab and the underlying rhythm is identified and the area that's causing the atrial fib is ablated. Other treatments for atrial fibrillation is adenosine IV push or Adenocard, or beta blockers or calcium channel blockers. Atrial fibrillation, the next slide shows what happens and what actually goes on in the heart during atrial fibrillation. And you can see that there's a pooling of blood in the heart when the atria are fibrillating. And then if the patient happens to convert into sinus rhythm, what happens is these clots are thrown into the systemic circulation. And most often, because of the proximity of the brain to the heart, they end up in the heart and cause a stroke. Atrial flutter. Atrial flutter has its same problematic issues, the same as atrial fib, in that it causes pooling in the atria and it causes other problems. The difference between atrial fib and atrial flutter is that there is contraction within the atria. However, it's very, very fast and not effective. So atrial flutter is textbook characteristic for that sawtooth pattern that you're seeing on the monitor there with the patient's P waves. The rhythm of atrial flutter can be regular for the most part. Oftentimes it is irregular. It just depends on what's going on with the patient. The P wave is a sawtooth pattern that's not measurable, and the QRS complex most often is less than 0.12. Treatment, again, for unstable atrial flutter is cardioversion. Stable atrial flutter with a narrow QRS complex is rapid IV push adenocard or adenosine or antiarrhythmics. And there are various ones that can be used. Which of the following arrhythmias creates the most significant risk for cerebral vascular accident? Answer: atrial fibrillation. There's a high risk for embolization of the atrial thrombi. These thrombi are implicated in many cases of stroke. Ventricular arrhythmias. Ventricular arrhythmias are abnormal ventricular conduction, often down through the bundles. Premature ventricular complexes, or PVCs, occur oftentimes with patients with cardiac irritability. PVCs are often seen in patients who've had an MI or patients who have a potassium disturbance of some type. Premature ventricular complexes are warning signs for ventricular tachycardia and ventricular fibrillation, and they need to be treated aggressively, especially if the patient has most recently had an MI. Premature ventricular complexes, if you have more than 6 per minute, should definitely be treated. If you're seeing more than 2 or 3 together, those are considered VTAC, more than 3, and you want to make sure that you're treating these again. Ventricular arrhythmias such as ventricular tachycardia and ventricular fibrillation can be life-threatening. These are signs of cardiac irritability, signs of low potassium, or signs of hypoxia, or all 3, and they often deteriorate into life-threatening arrhythmias. Ventricular rhythms. The P waves, there are none, especially with PVCs, there are none. The PR interval is absent because the atria are not working. The QRS duration is greater than 0.12 and of opposite deflection of the T wave. The rhythm is regular. The rate interrupts the underlying rhythm or is rapid. And treatment of PVCs is O2, correct the underlying problem if it's hypoxia or potassium, and if symptomatic, amiodarone. In ventricular tachycardia, you want to make sure you check a pulse. If VTAC is pulseless, it's treated as ventricular fibrillation. If you have a pulse in VTAC, then again, you apply O2, you correct the underlying problem, you make sure the potassium is appropriate, and if a pulse, it's amiodarone or adenocard. If no pulse, then you defibrillate. And I can't stress enough on your patients to make sure that you're applying O2 to these patients and oftentimes, sometimes even that will be enough to get rid of the PVCs. Here's a slide of unifocal, which means from the same focus, PVCs. In other words, these PVCs are coming from the same irritable place in the heart. And if you notice on this slide, you'll see this wide complex QRS here, and that's indicative of your PVC. The next slide shows a large run of VTAC. And if you'll notice here on this slide, you have no P wave. You have wide ventricular complexes, and they're rapid. Again, ventricular tachycardia, you check a pulse. If you don't have a pulse, you defibrillate. If you have a pulse, you treat with O2, with making sure their potassium is appropriate, and with amiodarone or adenocard. Okay, More ventricular rhythms. Ventricular fibrillation. P waves, you have none. PR interval, you have none. QRS duration is wide and irregular. The rhythm is irregular. The rate is often in excess of 150 beats per minute. And VFib, you defib. And that's the nice thing about ventricular fibrillation is it's usually very easy to recognize, and it's also easy to treat. However, it's a very, very serious rhythm. So remember, ventricular fibrillation, VFib, you defib. Our next rhythm we'll talk about is asystole. In asystole, you have a complete absence of cardiac electrical activity. So you will see a straight line on the monitor. One of the things that's important to remember in asystole is that you must confirm it in a second lead. In other words, if you have your patient and you're monitoring them in lead 2, then you need to switch your monitoring lead to a different lead in the heart, one of the other ones, and make sure you still have asystole. And the other thing is you confirm unresponsiveness. So if your patient is asystolic, then it's epinephrine or vasopressin. Epinephrine is a vasopressor that's given in these patients to help stimulate cardiac activity. It can be given every 3 minutes, 1 milligram every 3 minutes. Vasopressin is a one-time dose of 40 international units IV. And most clinicians will give the vasopressin within the first 1 to 2 doses of epinephrine to avoid forgetting to give the medication because it is a one-time dose. And if either one of these medications are ineffective, then we move to cardiac pacing. This slide shows a picture of ventricular fibrillation. And if you note, you have a very irregular complex here versus ventricular tachycardia where it's regular. And that's the difference between VFib and VTach. This next slide shows ventricular asystole. And again, you want to make sure you confirm this in a second lead and confirm that your patient is pretty much unresponsive, because this can also mimic having a lead off on your patient. Question. A patient has been brought to the emergency department in ventricular asystole. The priority for this patient's care is C. Cardiopulmonary resuscitation. Asystole is treated by focusing first and foremost on high-quality CPR with minimal interruptions and on identifying underlying and contributing factors. And one of the things that's very important to note, that CPR must be done early and quick. Heart blocks. Heart blocks are difficult. Those are one of the things that I think that students struggle with the most. And so we're going to try to break this down simply so that hopefully you understand this. And please make sure to note that you will not receive a strip on your test about heart blocks. You will just have to identify what type of treatment you would give with the heart block and understand how the heart block affects the patient. First degree heart block is really quite simple, because first degree heart block is basically just a sinus rhythm with a very long PR interval. It's greater than 0.20, but it's consistent throughout the strip. So first degree heart block is easy to identify. And normally the rate on first degree heart block is 60 to 100 beats a minute. One of the most common causes of first degree heart block is DIG or beta blockers. So oftentimes when we see first degree heart block develop on patients, we question their medications. Is it DIG? Is it a beta blocker? And then we also observe for increasing PR interval. We really don't treat first degree heart block unless we feel like it's going to become a very large problem. And then again, we look for it to deteriorate into something else. Second degree heart block type 1, or Wenckebach, the P waves are upright. The PR interval gets progressively longer until a QRS is dropped, but the PR interval gets progressively longer in a systematic fashion. For example, on the strip, if you note that the PR interval is the first one that you see is 0.22, then you measure the next one and it's 0.24, and then you measure the next one and it's 0.26, and then you'll see a QRS that's dropped. And then if you look at the strip, those same progression of numbers happen again. And that's kind of the hallmark of Wenckebach. The progressively longer PR interval causes the rhythm to be regularly irregular. The rate varies, but for the most part, heart blocks are going to have a rate that's less than 60, because what you have going on is a blockage somewhere in the bundle of His or the bundle branches. So in second degree type 1 Wenckebach, you really want to look at that PR interval. And again, Wenckebach is one of those heart blocks that can be expected after the patient has a right inferior MI. So very often, if the patient's had an inferior MI and we see Wenckebach, we really just watch it, because oftentimes it just goes away on its own. Another thing with Wenckebach, again, question their medications. If they're symptomatic, you want to maybe think about an external pacemaker. If the blood pressure is low, you might try a fluid bolus and dopamine. We really refrain from treating second-degree heart block with atropine, because oftentimes it's transient and it goes away. This slide here shows a first-degree AV block. And in this slide, the PR interval, if you notice, takes up one box, which is 0.20, and almost half of the next box, which is about 0.10. So this PR interval here on this patient is about 0.30, which is pretty long. This next slide shows second-degree heart block type 1 Wenckebach. And if you'll notice, the PR interval on this patient's rhythm gets longer each time. That first interval takes up about a box, which is 0.20. The next one looks to be about 0.28, and the next one takes up almost a box and a half, which is 0.30. And if you notice, then the QRS complex is dropped after that P wave, and then it starts all over again. This is textbook Wenckebach in this slide. Okay. Heart blocks, third degree. Third degree heart block is a complete block of the atria and ventricles. The P waves will be upright, but you won't have a PR interval. The QRS duration will be either less than or greater than 0.12, but the rhythm will be very irregular. And one of the things that happens in third degree heart block is that the atrial rate is independent of the ventricular rate. So you have P waves and QRS is present, but you have no relationship to each other. And in third degree heart block, pacing is indicated, and if the blood pressure is low, it's fluids or dopamine. If third degree heart block isn't being caused by medications such as DIG and beta blockers, then it's always indicated to put a permanent pacemaker in these patients. This next slide shows third degree atrioventricular block. And if you notice, you have P waves running across this strip, and you have QRSs, but they don't have any relationship to each other. And when patients get into third degree heart block, the only thing that really sustains their heart rate are those ventricular complexes. And if you notice on this strip, these ventricular complexes are about 40 for a rate. This is way too low for this patient to not develop symptoms and develop problems. Nursing assessment of the patient with an arrhythmia. A health history on these patients is critical. You need to understand which kind of medications they're on, if they have a cardiac history, and many, many other different things. So make sure you're taking a very detailed history. You want to look for signs of decreased cardiac output. Is their blood pressure low? Are their pulses good? What's their color look like? Coexisting conditions that could be a possible cause. It's important to understand if they have any pre-existing cardiac problems. Again, a medication history is crucial. Also, look for signs of fluid overload, such as venous neck distension, crackles, wheezes, edema. Pay particular attention to their blood pressure, also noting their mean arterial pressure. As I noted in my previous lecture before, mean arterial pressure is a very good indicator of how well your patient is perfusing their kidney and their brain. If your mean arterial pressure is less than 65, your patient is not perfusing adequately. So even if they have an adequate systolic blood pressure, but their mean is low, then you want to make sure you're addressing that. Also, auscultation for extra heart sounds, rate and rhythm of the apical, and their peripheral pulses. Nursing interventions for the patient with an arrhythmia include monitoring and managing the arrhythmia, minimizing anxiety, and teaching patients appropriate self-care so that they don't continue to develop these types of arrhythmias and that they follow their medication regime to make sure that they don't develop further dysrhythmias. Treatments for arrhythmias include cardioversion and defibrillation. And we'll talk about that more. I have a PowerPoint that will discuss about the differences in that. Defibrillation can also be done by an implantable cardioverted defibrillator. Patients often need a pacemaker. We'll discuss those. Electrophysiology or EP studies and cardiac conduction surgeries. Cardioversion versus defibrillation. Cardioversion is a shock that is done in emergencies for patients experiencing symptoms from ventricular or supraventricular tachyarrhythmias that are not responding to medical therapy. Cardioversion is a synchronized shock. In other words, synchronized means it senses the R wave on the patient's EKG. So if you look at the PQRST on the monitor, a synchronized shock will sense the R wave and fire its electrical energy on the R wave. And why is this important? Later on when we talk about defibrillation, it's very important. Indications for cardioversion are supraventricular tachycardia, ventricular tachycardia with a pulse, and some atrial fibrillation and fibrillation, atrial fibs and flutters that don't respond to medication. The joules are the amount of electricity that is delivered to the patient. In a monophasic defibrillator, which is your older defibrillators, it's 50 to 100 joules. In a biphasic defibrillator, which are the newer ones, it's 25 to 50 joules. And I'm sure you're wondering what's the difference between a monophasic and a biphasic defibrillator. The monophasic, the electrical energy goes across the chest, and in the biphasic, it goes from the front to the back. The nice thing about the biphasic defibrillator is it allows less energy delivery, thereby resulting in earlier cardiac conversion and less electrical energy to the patient, thereby being safer. There are no differences that have been found between monophasic and biphasic defibrillation as far as superiority in detracting the rhythm. So that's one of the things that you need to keep in mind, that if you have a monophasic defibrillator, it is a completely fine machine to use, and the outcome most of the time will be the same. If you can all, at possible, sedate your patient for a cardioversion, that's really nice to do. However, sometimes that's not possible. And sedation will depend upon whether or not the rhythm is causing disturbances in the patient's blood pressure. Obviously, if you have a blood pressure, a systolic blood pressure of less than 90, then sedation is probably not an option. Problems with cardioversion and defibrillation. In both monitors, make sure the defibrillator pads are not dry. When you take them out of the package, they should feel moist and sticky. If they're not going to work. Also, make sure your battery is charged. Monitors will not work if the battery is not charged. And make sure, this is most important, that you're familiar with your equipment. In a cardioversion, you must have the sync button set on the monitor in order for the monitor to work. If you're attempting to do a cardioversion and the patient has a shockable rhythm, and the sync is not on, the monitor will not work then. You'll be shocking them just at an interval where it isn't most effective. And again, whenever you're doing a cardioversion, you want to be prepared for worsening arrhythmias and have resuscitation equipment such as an ambu bag and medications by the bedside. Defibrillation. Defibrillation is a shock that is done in emergencies for patients experiencing pulseless VTach or VFib. And the difference between cardioversion and defibrillation is that the rhythms that you defibrillate, they do not have a viable R wave. These patients don't have atrial activity. Therefore, you need to make sure that you're defibrillating these types of patients. And remember, VFib, you defib. In ventricular fibrillation, one of the most early defibrillation has been found to be the most effective treatment for that rhythm. In the type of countershock in defibrillation is asynchronized. In other words, because there's not an R wave to sense, you don't need to have the monitor on sync. And keeping in mind that if you go to defibrillate a patient and the monitor is on sync, the monitor will not discharge because it will not sense an R wave. Indications for defibrillation are pulseless VTach or ventricular fibrillation. The joules that you start at for a monophasic defibrillator are 200. Then you go to 300, and then if no effect, go to 360. And in your biphasic defibrillator patients, if you have VFib or VTach, you're going to start your biphasic at 120 joules, and if that isn't effective, you go to 150. Sedation will probably not be indicated in your patients with VTach or VFib because most of the time these people are unresponsive. And again, don't forget to have the sync button off or the monitor waits for the R wave and won't defibrillate. And keep staff away from the bed during defibrillation. If they are touching the bed while the shock is delivered, it will shock them also. So always make sure that you're yelling clear before you defibrillate a patient. And this is true even with a hands-off defibrillator. Cardioversion versus defibrillation. If defibrillation is not available, you can do what's called a precordial thump, where you take your fist and thump on the precordium between the sternum, on the sternum, if it's a witnessed pulseless VTach or VFib. Biphasic defibrillations shock from front to back and therefore require less energy for cardioversion or defibrillation. And again, the joules here are listed for what you need. This next slide just shows a couple of things. If you are doing an elective cardioversion, then you do need to have a consent form. Otherwise, we shock first, ask questions later. A nurse on a cardiac unit is caring for a group of clients. The nurse should recognize which of the following clients is being at risk for the development of a dysrhythmia. D and E. A client who has an acid-base imbalance, such as metabolic alkalosis, is at risk for dysrhythmia. A client who has a lung disease, such as COPD, is also at risk for a dysrhythmia. A client who has cardiac disease and underwent a stent placement is also at risk for a dysrhythmia. A serum potassium of 4.3 is expected and normal, and a SAT of 96% is the expected reference range for a patient. Is normal. The next question we'll be working on in class. The following questions will be covered in class. Implantable automatic cardioverter defibrillator is indicated for clients who have experienced one or more episodes of sustained VTach or VFib unrelated to an MI or other correctable causes. The client undergoes electrophysiology studies to assess the inducibility of VTach and its response to medication. If the dysrhythmias can be induced despite medical therapy, then the client is a candidate for an AICD. The AICD is implanted in almost the same fashion as the permanent pacemaker. The electronic pulse generator is designed to monitor and defibrillate for VTach and VFib, and some advanced generators even have pacing capability. Pacemakers are of several types: non-invasive, often referred to as an external; invasive, which is the transvenous, which is a catheter threaded through the heart to the right ventricle, and by electrical stimulation it paces the heart. The epicardial invasive is has separate lead wires that are loosely threaded on the epicardial surface of the heart after heart surgery, and the wires exit through the chest wall. They are connected to a pulse generator. There are two types of pacemakers. There's a single chamber and a dual chamber. The single chamber pacemaker is not often inserted anymore because the dual chamber allows the practitioner to be able to have both chambers paced or to turn a lead off if necessary. So the dual chamber is used most often, and the lead wires are placed in both the right atrium and the right ventricle. The following chart shows pacemakers of several different types. The non-invasive temporary pacemaker is external. It has two large patch electrodes that are applied to the chest wall in the front and the back, and it's connected to an external generator, which operates on AC current. Indications for the non-invasive external temporary pacemaker are emergencies where there's not time to use other pacers, hospitals that do not use other therapies, clients are at risk for bradycardia. You can use this type of a pacemaker until other therapies are available. The non-invasive temporary external pacemaker is indicated for asystole, bradycardia, and heart block. Some of the perils and pitfalls of this type of pacing is that it can be very uncomfortable, it may be hard to regulate, and it may be costly. The invasive temporary pacemakers that are internal, such as the transvenous or the epicardial, some clients that have a dysfunctional sinus node but an intact AV node may need these types of pacemakers. Most common are the inferior MI or drug disturbances. The epicardial is used prophylactically after heart surgery. These types of pacemakers are indicated for bradycardia and heart block that happens in these types of patients. The perils and pitfalls of the invasive temporary pacemakers, both transvenous and epicardial, include patients can dislodge the catheter, the generator can become disconnected, or there can be battery failure. The invasive pulmonary pacemaker is internal, and the client is taken to the OR and lead wires are threaded into the heart transvenously. The generator is implanted in the subacute pocket of the right or left subclavicular area in the pectoralis major muscle. Indications for this type of a pacemaker are resolution of conduction disorders that are not temporary. Most often, this includes complete heart block or third-degree heart block and sick-sinus syndrome. One of the perils of pitfalls of an invasive permanent pacemaker is that the lead wires can dysfunction. There can be hematoma or infection at the operative site, and there can be battery failure. There are two different types of modes of pacing. One is demand pacing, where the pacemaker's sensitivity is set to sense the client's own heart rate, and when the heart rate falls below the specified rate, the pacemaker takes over and initiates an impulse. The other type of pacing is asynchronous or fixed-rate pacing, and this is used when the patient is profoundly asystolic or bradycardic, as may often occur in cardiac arrest or post-heart surgery. The pulse generator is set so that it does not sense any of the patient's own heart rate, and it continues to fire at a specified rate regardless of the client's own rate. Complications of pacing. Several complications can occur with pacing. One is infection at the insertion site, loss of capture, where the pacemaker doesn't understand when to fire, non-sensing, where the pacemaker can't find the complex to pace, interference, which is usually electrical types of things. One of the things to note is that it's not recommended that patients carry their cell phones in their chest pocket of their shirts on the side where their pacemaker is. Microwaves and those types of things often don't affect pacemakers anymore because the new ones are so sophisticated. Stimulation of the chest wall can be a problem, and there are other different types of malfunctions that are found in Table 17.3 in the Pellico textbook. Postoperative care of permanent pacemakers and AICD clients includes monitoring for arrhythmias. It's crucial in the first 12 to 24 hours that you're monitoring these patients closely for any types of rhythms that may develop. Also, make sure you're monitoring the insertion site for redness, swelling, hematoma, or any of those other types of things, and also make sure you're monitoring their lab work. Monitor their vital signs carefully, paying particular attention to their heart rate, especially in demand pacemakers where they're making sure that the heart rate doesn't drop below the preset level. In the first 12 hours, it's kind of important to limit their activity. You don't want the patient raising their arms over their head for several days. And in that first 12 hours post-op, we keep them a little bit more on the quiet side. Once that 12 hours has passed, though, and into the next day, it's important to resume their normal activities so that you can see how well these patients are tolerating the devices that are implanted. Another thing that's a nursing responsibility is to make sure you're setting up their post-discharge checks. Patients need to have these devices monitored on a monthly basis to make sure the settings are maintained and that all the operating mechanisms within the devices are functioning correctly. This can be done over the telephone, but the patient needs to make sure that they're doing it and that you've set them up for doing this. Question: when providing care for a patient with an implantable pacemaker, what assessment would be a priority? In this case, B, pulse. It's important to make sure that you check their pulse and report any sudden slowing or increasing of pulse rate. A nurse is admitting a client to the coronary care unit following placement of a temporary pacemaker. Which of the following nursing actions should the nurse use to promote client safety? Gloves are worn when handling pacemaker leads. 3-pronged grounding plugs reduce the risk of accidental electrical discharge by the equipment being used. The client's shoulder movement should be minimized, or the client should wear a sling to promote secure anchoring of the lead wires. The lead wires should have some slack in them to prevent dislodging the wires when the client is turned. Additional batteries should be kept at the client's bedside for quick access when needed. A nurse is admitting a client who has a complete heart block as demonstrated by EKG. The client's pulse rate is 34, blood pressure is 83/48. The patient's lethargic and unable to complete sentences. Which of the following actions is the best action for the nurse to perform first? Before applying transcutaneous pacemaker pads, the client's skin is cleaned with soap and water and dried thoroughly. A client in complete heart block should be prepared for the insertion of a permanent pacemaker, but this is not the first action by the nurse. Informed consent is needed before transcutaneous pacing can occur, but this is not the first action by the nurse. And a client in complete heart block requires external transcutaneous pacing prior to the insertion of a pacemaker, but this is not the first action by the nurse. A client is caring for a nurse following the insertion of a temporary venous pacemaker via the femoral artery that is set at a rate of 70. Which of the following findings should the nurse report to the care provider? A and C. A cool, clammy foot could be an indication of a femoral hematoma secondary to insertion of the lead wires, and that should be reported. Twitching of the intercostal muscle may indicate lead wire perforation and stimulation of the diaphragm and should be reported. The following other answers to that question were all expected findings.